Good evening, everybody. Great pleasure to be back here again. We're going to have a lively discussion today, and hopefully you'll come away with some information that'll be helpful to you. The topic of discussion today is one that so many people confront in the IVF arena, and that is they get a surprise when the quality of their eggs is not good, or they yield very few eggs after egg retrieval. This subject matter today, some of it will be repetitive on what we've discussed before, but it's going to focus on this primarily. How do we optimize the number and quality of eggs we get at IVF? But this needs to be done within the context of a bit of background information. Okay, now, firstly, this presentation will take about 40 minutes. I'm going to try to keep it as short as I can, so we have time, lots of time for questions and answers. Please submit your questions in the chat box next to the video window anytime you choose. The sooner you put those questions down, the sooner they will... which one do I push to move forward? That one there, okay. As soon as you type your questions in, the sooner you do it, the better, because you'll be able to get in first with your questions. Any additional questions that don't get answered today, I suggest you post them on the discussion boards at forumshaveababy.com, or go to my blog, ivfauthority.com. There is a question and answer session. There's a bulletin board there where you can post any questions or issues, and I'll be happy to come back and answer them. As those of you that have been there know, I try to frequent that board as frequently as I possibly can. But post the questions you have for me, and to get there, go to haveababy.com, to the SRM Las Vegas discussion board specifically, and I will address them myself. Again, it's those two locations, forumshaveababy.com, Las Vegas discussion board, and then ivfauthority.com, where you can also read on other topics that I've posted there. Another point that I want to bring across right at the inception, and I'll be mentioning this over and over again, please schedule a consultation with me through through Skype by calling 800-780-7437. I invite every one of you to do that. Call up and speak with Tina. Tell Tina to book you for a Skype consultation where we can visually make contact, and I can answer your questions one-on-one and go over your case in detail and help solve your problem with you. Okay, we're going to be starting off today, talking about the factors that influence egg yield and quality. By yield, I mean the number of eggs and, of course, the quality of the eggs that you get as well. So I'm going to start off now by just going over some of those factors with you. The first one, and the most important one, of course, is the age of the woman. The older the woman becomes, obviously the poorer the quality of her eggs. As you'll hear in a few moments, the most important factor in egg quality has to do with the chromosomal integrity of the woman's eggs. In a young woman in her late 20s and very early 30s, almost 1 in 2 eggs will be normal, have a full component of chromosomes when it's ovulated or extracted. And as a woman gets older, when she gets to about 34, 35, maybe 1 in 3, when she gets to close to her 40s, it's 1 in 7 or 8. When she gets to her early 40s, 42, 43, only about 1 in 10 or 12 eggs is going to be normal. And then at about 45, only 1 in 20 is normal. So you can see there is a decline in egg quality as women get older. And if the egg is abnormal, the embryo will be abnormal chromosomally. A normal embryo must have 46 chromosomes, 23 from the man, 46 chromosomes, 23 from the egg and 23 from the sperm, adding together 46. If there's even one more or one less than 46 chromosomes in the embryo, such an embryo is deemed aneuploid. And an aneuploid embryo is incompetent, incapable of making an embryo that can result in the birth of a healthy baby. Most aneuploid embryos never even reach the point of attachment. Some do attach, but very briefly, and they don't stay there very long, so you don't even know you're pregnant. Others stay long enough for the pregnancy test to become positive, but not much longer, and that's called a chemical pregnancy. and then others will stay on and be lost later as a miscarriage, usually in the first 12 weeks of pregnancy or the first trimester. So for the embryo to be normal, the egg has to start off being normal, and the center of normality of the egg relates to its chromosomal integrity. And that in turn is primarily affected, but not exclusively, by the woman's age. Another factor that affects the quality of the egg is how that egg will develop once it's in the ovary under the effect of hormones that stimulate it, like FSH. And that is affected by the protocol of stimulation used in IVF. I want to say this categorically, so please hear me out on this. By far, the most important determinant of whether a woman is going to get pregnant with IVF is whether her eggs are going to be normal. And the most important thing that we as doctors can do to contribute towards that happening is to design and implement an ideal protocol. There is no same size, or there is no ideal one-size-fits-all protocol for every individual, any more than there's no single height or weight for any individual. It's got to be designed and it's got to be implemented in a very strategic and individualized way. Most people that seek help for poor egg quality need to receive that help in the form of a designer-made protocol that suits their needs optimally. Even doing that may not optimize egg quality for some, and for those people there's very little that you can do. You end up having to resort to egg donation, where you can get eggs from a younger woman that is of good quality. But by and large, the age of the woman will set the potential of the egg to be normal, and then the protocol used for ovarian stimulation will impact upon whether or not in that woman those eggs are protected and can develop normally. Because if they don't develop normally, they won't ripen or mature normally in the last 36 hours before they're harvested. That is the time after the HCG shot is given, which halves the chromosomes in the egg and has to do so precisely for that egg to be mature and ready to be able to make a healthy embryo upon fertilization. The second concept, other than age and the protocol used for ovarian stimulation, is ovarian reserve. What ovarian reserve is the number of eggs that are left in the ovary available for being used cyclically each month that the woman undergoes a regular ovulation cycle or is stimulated. So the ovarian reserve, the number of eggs that are left in the ovary, it can be measured by looking at the woman's FSH level in her blood on the 2nd to the 4th day of her period, and more recently, and I believe more finitely, by using the anti-Mullerian hormone, or AMH level. The AMH level can be done any time in the cycle. Another one that we sometimes use is the measurement of inhibin B. But FSH and AMH, FSH done on day 2 to day 4 of the cycle from the woman's blood, and AMH, anti-Mullerian hormone, measured in the blood any time in the cycle. An FSH level at the basal level, that means at the stage I mentioned, that is over 9, usually suggests that the woman is running out of eggs and there's fewer available to be stimulated. An AMH of 2 or greater, 2.0 nanograms per milliliter, is normal. 1 to 2 is in the intermediate zone, and under 1 shows significantly diminished ovarian reserve. When the AMH drops below 0.5 nanograms per milliliter, that's a critically low level, and such women are moving rapidly towards the final stages where they run out of ovarian reserve and enter the menopause. In most women, ovarian reserve will be fine in their up to their mid-30s. Between 35 and 40, it goes down slightly, and after 40, it usually goes down more quickly. But you can be surprised. Some women in their mid-40s can have a very high ovarian reserve. And that means there's plenty of eggs still available for use. The fourth factor that influences the egg quality and the yield will be the HCG trigger. I'm going to talk about this later. How do you trigger the final maturation of the eggs? Because in the 36 hours preceding ovulation or egg extraction, the egg undergoes a reduction in its chromosome number. This reduction needs to be an exact halving from what was 46 chromosomes up to that point, down to 23. The mature egg has exactly 23 chromosomes. The other 23 are packaged in a little envelopment and flung out of the egg, and they come to lie under the envelopment of the egg known as the zona pellucida. This envelopment is called the polar body. I'm going to show you photographs of this in a few moments. The HCG trigger causes the eggs to go through this reduction division or maturation division, also known as a ripening division. We refer to this process of division, this maturational division, as meiosis. It is the rate-limiting factor in human reproduction, and if the egg is not developed normally up to the point that it is forced to go into meiosis by the HCG trigger, that egg will not divide straight down the middle, and you'll have a greater likelihood that that egg is going to be aneuploid and incompetent, incapable of making good quality embryos. The HCG trigger can be given by using Prophase, Novarel, or Pregnile. These are derived from the urine of pregnant women, purified, and this is was of course pregnant women put out a lot of HCG in their urine. It's then purified and injected. The ideal, and I believe to be the only reliable dose, is 10,000 units of HCG. More recently, a product known as Ovidrel, and in some countries called Ovitrel, was designer made. It is a recombinant DNA form of HCG. The problem is that Ovitrel or Ovidrel, to be effective, please hear me on this, should ideally be administered in double the dose that it comes in a single vial. It comes in a 250 microgram vial. I believe that 250 microgram is probably equal to half the 10,000 units of HCG. In other words, it's equal to about 5,000 units of HCG, which is insufficient. 500 micrograms of Ovitrel equates with, in its biological activity, about 10,000 units of HCG, and is the ideal dosage to use. Other methods of triggering meiosis to mature the eggs in the 36 hours before they're released or extracted is to use a hormone called lupron, which is an agonist. Other equivalents are things like superfact. Lupron causes the woman's pituitary to release a surge of LH, and the surge in LH then triggers meiosis. It is a way to go. I don't particularly like using this approach because you never know exactly how much LH the woman's pituitary will release. And if she's been on drugs that block LH in the pituitary, such as antagonists, or on Lupron, it's often not going to release a surge of LH at the level you want it to release. So I prefer to use, personally, my preference is regular urinary HCG, 10,000 units in the form of Prophase, Pregnile, or Novarel. Then the final factor that obviously will influence egg yield and quality is technical expertise in extracting the eggs. And of course, that's not something we can discuss here. Most doctors who do IVF have the required expertise to extract the eggs, but sometimes the eggs won't come out of the follicles because they remain densely stuck or adherent to the inner wall of the follicle. This often happens if the egg's very abnormal, because in order to be able to come out, when you put a needle in the follicle and suck the egg out, it has to be hanging loosely, literally on a thread into the fluid inside the follicle. And for this to happen, the egg has to be able to signal the cells around it after the HCG trigger. It needs to signal the cells that bind it to the inner wall to loosen up so it can be hanging freely in the fluid and come out in the needle when you hit the pedal and suck through the needle. But if the egg is grossly abnormal, if it's severely aneuploid, we call it complex aneuploid, it often cannot send the message to the cells that bind it, and it remains densely stuck to the inner wall of the follicle. In my opinion, there is no such thing as an empty follicle. All follicles have eggs, or they wouldn't be follicles. Whether the egg can come out very much depends upon whether or not the eggs can disperse the cells around them and come to lie loosely inside the fluid. And that requires an ideal protocol of stimulation and a proper HCG trigger. The second technical aspect is in the laboratory. And obviously most IVF laboratories have the sufficient expertise to fertilize eggs properly. Today, most of us fertilize the eggs by ICSI. So it's extremely important to know that the processing of the egg is very much linked to what goes on in the laboratory, but it is rare, I repeat, it is rare for the eggs to be damaged through anything done by the laboratory. When there's something wrong with the egg, it's either because there's an inherent problem in the woman's ability because of her age and her ovarian reserve to actually produce good eggs, or it has to do with the wrong protocol of ovarian stimulation used in the process of making those eggs develop. All right, let's move on. So let's talk about the concept quickly of the biological clock, because most of you are aware that the woman that is most at risk of not having good quality eggs is a woman who's older, or a woman who's running out of eggs, or both. There are two components to the biological clock. The first one is something I mentioned earlier, ovarian reserve. How many eggs are left in the ovaries? And as this number of eggs that populate the ovaries declines as the woman gets closer to menopause, she'll have fewer eggs available. And as her egg, and when her eggs, the total number left over in the ovaries, falls below a certain threshold, that is when she starts running out of reserve, and we pick it up by measuring her FSH as it goes ever more progressively above 9 milli-international units per milliliter, and her AMH falls below 2 nanograms per milliliter, and then ultimately below 1 as things become more grave. And there's nothing we can do to change this. All we can do is to stimulate the woman more as aggressively as she needs to be stimulated to be able to harvest all the eggs. I often sit by and I'm blown away when I see how many people think that using a mini dose stimulation will improve their yield of eggs. It does not do that. It's like saying you got a heavier rock sitting on the top of a hill and you want it to roll down the hill in the direction you push it, so just push more lightly. Makes no sense. You've got to be able to push, you've got to be able to stimulate more aggressively the lower the ovarian reserve. The second issue, as I mentioned earlier on the biological clock, is that with age, the quality of the eggs declines because of the increasing risk of aneuploidy, which I mentioned. It just so happens that ovarian reserve and declining egg quality become a problem that's more progressive as the woman gets older. But some women go into menopause in their early 30s, and their ovarian reserve will start declining 7 or 8 years before then. Such women still have good eggs because they're younger, but the eggs are harder to get at. And here comes another important point. It's very difficult to stimulate women adequately and preserve egg quality when there are fewer eggs around. They become much more vulnerable to the issue of egg quality. You use a protocol that's injudicious in a woman that's young, you'll get away with it. In a woman with normal ovarian reserve, you'll get away with it. But you use an injudicious protocol in a woman that has got diminished ovarian reserve, or in someone that's older, you'll usually worsen the quality of the eggs in so doing. And that's the key. You've got to individualize the protocols of ovarian stimulation more so as women get older to avoid this effect. So as I told you earlier on, it's primarily the egg rather than the sperm that will determine whether the embryo is going to be competent. Sure, if a man's got very severely compromised sperm, embryo quality will be compromised because the sperm will influence the incidence of aneuploidy of the embryo. But by and large, it is rather the egg than the sperm that plays the predominant role in dictating whether the embryo is going to be normal and competent. This is just a slide to show that wonderful, miraculous process starting called meiosis, where the egg halves its chromosomes in the 36 hours prior to it being ovulated or extracted. And here's a picture of a beautiful mature egg. Notice the surrounding envelopment called the zona pellucida, and this is the egg here. Notice also this little envelopment, this polar body, and when you see that polar body outside the egg, it's been expelled from inside the egg with hopefully half the number of chromosomes, then you know the egg has gone through meiosis. If you don't see a polar body, as in this egg, where you've got an egg that doesn't have the polar body extracted, then you know that what's left inside the egg is all 46 chromosomes. And such an egg is immature because it hasn't gone through the maturational process called meiosis, which expels the polar body here. Now, an egg that is not healthy sometimes is irregular in contour. Sometimes it has little spaces inside it, little water-filled spaces we call vacuoles. Sometimes it has fragments in it. But by and large, an abnormal egg can look just the same as a normal egg, because while we know that half the chromosomes are supposed to be expelled by way of this polar body, which, by the way, disintegrates and disappears within a few days, we don't know that exactly a half went out with the polar body. So you could have a number left in the egg which is short of or more than 23, half of 46. And you won't see that by looking at the egg under the microscope. The only way you can be sure that the egg has 23 chromosomes is to remove that polar body. You make a little hiatus with a laser here, extract the polar body, and test the chromosomes in that body. Because this, the chromosomes in the egg, will be a mirror image of what's there. So if you've got 23 here, when you test it by CGH, then you know there are 23 left. When there's more than 23 in the egg, then you know that there's less than 23 inside. If there's more than 23 in the polar body, you know there's less than 23 left in the egg, and such an egg is going to be aneuploid and unable to propagate a viable pregnancy. Just by way of a little pearl here for you to think about. You've all heard so much about egg banking, extracting eggs and freezing them for future use. In my opinion, unless you test the chromosomal concentration in the polar body, you never know that the egg you're freezing has got exactly the 23 chromosomes it needs to make a baby. So in our program, when we do egg freezing for people, or when we advocate egg banking, we usually like to do a test on the polar body known as CGH to make sure that the eggs we are freezing are normal. And an egg that's normal that you freeze will have 6 times greater chance of propagating a viable embryo, one that can make a baby, than an egg that looks like this one here, normal, but in reality may be aneuploid. So to me, egg freezing should ideally be combined with CGH testing of that polar body. So no embryology laboratory can yield a competent quality embryo if you deliver to them chromosomally abnormal aneuploid eggs. There is no medication that can make an egg. There's no procedure in the laboratory that can convert an incompetent aneuploid egg and make it a competent euploid egg that can make a baby. It's what you do before the eggs reach the laboratory that gives you the chance, greater or less, or none, or total, of giving good or abnormal aneuploid or normal euploid eggs to the embryologist. And that's what they depend on. So often the embryologist gets blamed when embryos are not good quality. Truth be known, it's not his fault or her fault usually. It's usually to do with egg quality, which sometimes could be improved by helping the eggs develop normally before they enter that maturation or division through the proper selection of protocols of stimulation. And then when you get the eggs and the embryos, of course, as you guys know from before, you can always test those eggs, as I just explained, by doing a polar body biopsy to see if it's normal, or you can test the embryo by testing some of the DNA in its cells to make sure that that embryo is normal by doing embryo CGH. So here is an egg after fertilization. You can see the two nuclei, one from the sperm and one from the egg. And here on day 2, it's divided in 2. And then by day 3 to day 9, by day 3, it should be 5 to 9 cells divided. Look how nicely these cells are equi-sized. But again, let me point out that even such an embryo can look as beautiful as this one and still be aneuploid and have more than or less than 46 chromosomes. This is a 5 to 6 day expanded blastocyst. This is the section that makes the baby. It is the inner cell mass, and these are the cells on the outside that are going to make the placenta and the membranes. This blastocyst is much more likely to be normal than an embryo is on day 3, because abnormal ones may not reach blastocyst. And I want to emphasize this again. An embryo that doesn't reach this stage of blastocyst development by day 5 to 6 is almost always chromosomally abnormal, incompetent, otherwise incapable of making a baby because it's aneuploid. An embryo that does not make blastocyst, doesn't go from this stage to this stage, is aneuploid. But a blastocyst that reaches this stage is more likely to be normal because many of the abnormal embryos died off along the way, but it's not always normal. It can still be abnormal. The most influential factor that we can manipulate as doctors, clinically, is to select, to engineer and implement a strategic protocol of ovarian stimulation. There is nothing, I repeat, nothing more important, more relevant to the outcome of IVF than the quality of the embryos, and nothing that we do to get there is more important than proper selection of the protocol of stimulation. In a young woman in her early or mid-30s who has got normal ovarian reserve, an FSH of under 9, an AMH of over 2, such a woman is going to be able to make some normal eggs and therefore normal embryos virtually no matter what you give her to stimulate her with. It's the women that have diminished ovarian reserve and the women that get beyond 35 and beyond 39 that are much more at risk of the eggs being pushed off the rails through an adverse protocol of stimulation. Now, a few words about this is very important and relevant to this discussion. Again, how do we determine the best protocol for stimulation? We take into consideration the woman's age. We take into consideration her ovarian reserve, how many eggs she's got left, and we look at how she responded before to whatever protocol she was on in stimulation. I guess another thing is, look at the woman's clinical condition. We could add a number 4. For example, a condition like polycystic ovarian syndrome, the woman has got an ovary with an adverse environment, I'll point it out to you a little bit later, and many, many more eggs, which often leads the doctor to be frightened that if she continues to stimulate the woman with fertility drugs for too long, she'll develop severe ovarian hyperstimulation syndrome, and therefore the doctor often will go ahead and extract the eggs too early. When the egg's not ready to receive the trigger of HCG, he'll give the trigger, and often to try to avoid hyperstimulation, will use a lower dose rather than the 10,000 units of HCG to trigger the meiosis. He'll use 5,000 units. And that is adverse. That is not good. So women, their clinical condition, such as PCOS, or women who are very, very young, or women that have got, who are not ovulating on their own, they tend to hyperstimulate. We have more of a problem in ensuring good quality eggs after stimulation. So what is it then about the egg, about the stimulation that matters? Well, first of all, I told you earlier on that the egg conducts events in the follicle. I want to point out to you, and I'm going to show you a slide now where you see a follicle here inside a slice of ovary with an egg inside that follicle here. And then you see cells lining the follicle here. These are the granulosa cells that make estrogen. And then surrounding that follicle, you'll see connective tissue known as stroma or theca. This area makes a hormone called testosterone. The testosterone is carried in a bucket brigade fashion from the theca to the granulosa cells here, where under the effect of FSH in the fertility drugs and the natural FSH that we all produce, it is converted from testosterone to estrogen, to estradiol. And as that happens, these cells multiply. The follicle stretches, fluid builds inside, and the estrogen gets pumped into the blood system, and we measure it in the blood, and we also measure the size of this follicle by ultrasound, which tells us how the follicle is growing. A little bit of testosterone is essential for egg development. Without it, you won't get estradiol being formed, you won't get follicle growth, and you won't get the egg developing. But too much testosterone is like a flood on your garden instead of a gentle drizzle. It gets into this fluid, compromises the development of the egg, and now, when you get to the point where the woman needs the HCG trigger, that egg is much more likely to be aneuploid and abnormal because of there being too much testosterone and other male hormones in the follicular fluid. So the question then is, we want a little bit of testosterone, not too much. What causes testosterone to be formed? Here, the testosterone that's carried to the follicle for estrogen production. It is the hormone LH, also produced by the pituitary. You need a little bit of LH to make a little bit of testosterone that'll get into the cells of the follicle, the granulosa cells, and be converted to estrogen. But a large amount of testosterone, because of a large amount of LH, is dangerous. It gets into the follicular fluid, corrupts the egg, and now when you give the HCG trigger, you are much more likely that that egg will become aneuploid. So then, who is at risk of making too much testosterone? It's women who produce too much LH. Who are they? These are women that are older and women with diminished ovarian reserve, elevated FSH and low AMH, and also women with polycystic ovarian syndrome, PCOS. So these women have to be very carefully stimulated to control the LH levels, to lower it before you begin the stimulation, so that you can prevent over access to LH by the connective tissue, the theca. In conditions where the woman gets older and in PCOS, this ovarian stroma, the theca, is overgrown. We call it hyperthecosis, or we call it stromal hyperplasia, overgrowth of these cells. So the ovaries are set up for disaster. Too much LH hits a much larger target, a much larger cellular area of stroma, and now too much testosterone is produced. And that is one of the reasons why women with PCOS have poorer quality eggs. It's also one of the reasons why older women and women with diminished reserve tend to produce poorer quality eggs if you do nothing to control the LH and therefore the testosterone before the stimulation begins. So a small amount of testosterone is essential, but too much testosterone is dangerous. It's a tsunami effect on the follicle and the eggs. Who's most vulnerable to too much androgens, male hormones, testosterone, and androstenedione? Older women, women with polycystic ovarian syndrome, and women who have lesions or tumors or cysts in the ovarian substance, because they activate the stromal tissue and cause it to produce too much testosterone. This is one of the reasons why tumors in the ovary or endometriomas are best removed before you do a stimulation for IVF. And that's my own personal opinion. From 30 years of experience, I honestly believe that a woman who's got more than a 1 centimeter endometrioma in the ovary should have it removed or treated with sclerotherapy, which is a different topic, before doing IVF. And tumors or cysts in the ovary should also be removed before you go into stimulation. Again, too much testosterone, too much androgens, poor follicle growth, and poor egg embryo quality, and low IVF success rates, because the egg will be of poor quality and the embryo will also be of poor quality. Another thing, if there is too much LH around, the granulosa cells that line the inside of the follicle undergo a process called luteinization. So if a woman's follicles are overexposed to too much LH, then those follicles become luteinized. And when that happens, the egg quality is compromised and the eggs don't easily come out of the ovary. They remain stuck to the inner wall of the ovary. When you put the needle in trying to suck the eggs out, you don't get them out. And very often you're erroneously told that the follicles were empty. There's no such thing as empty follicles. What you've got is a follicle that won't release its eggs because it's too tightly and densely stuck to the wall, because it's abnormal. And it's abnormal either because of age or because of an inherent defect in the egg in older women, or because of the wrong protocol of ovarian stimulation. Okay, so what causes overexposure? I said high LH, PCOS, ovarian resistance, and age. Using the wrong protocol. When you use protocols where you give a lot of clomiphene, clomiphene causes increased amounts of LH to reach the ovary. It's not ideal, and that's why, in my opinion, it is best not used in IVF at all, especially not in older women or women with diminished ovarian reserve, or in women with PCOS undergoing IVF. Flare protocols, where Lupron is given from the day the stimulation begins, causes or forces the LH into the circulation, so it hits the ovaries exactly as the eggs are trying to get out of the starting gates with stimulation. And that's why I don't believe in flare protocols for IVF at all, but in my opinion it's especially harmful if you give it to women who are older and women with diminished ovarian reserve. Yes, you may produce more follicles because the flare protocol also releases more FSH, so more follicles will start developing, but the quality of the eggs in the follicles are not good. And then if there are lesions, as I mentioned, cysts or tumors or endometriomas in the ovaries, these can also cause excessive amount of androgens. And then if you take too much androgen, especially for women that are older or have diminished ovarian reserve, giving them testosterone or giving them HCG adjuncts during the stimulation, which only causes the stroma to produce more testosterone, or giving them a supplement that I believe, in my opinion, is wrong, is overused and overprescribed, DHEA, especially to older women and women with diminished reserve where there's already too much testosterone around in the ovary. And so using DHEA, which converts to testosterone in the ovary, in my opinion, adds fuel to the fire and is not a good strategy. In a younger woman, it probably doesn't matter, but in an older woman with diminished reserve, So how do we limit exposure to androgens and protect the eggs? Limit the amount of LH exogenously, so use purified FSH. Don't use drugs in large amounts that contain FSH, contain LH and HCG, like Menopur. If you use high doses of drugs that contain LH or HCG, they'll only cause increased stromal testosterone production. Treat any lesions before you go to IVF. Remove cysts or endometriomas or tumors before you proceed to stimulation. And then give the woman a few weeks to recover before you proceed. Or if you've got a small endometrioma, aspirate it out of suck it out with a needle before you start the stimulation at baseline. And then use long protocols of stimulation. I think you need to use a birth control pill because that suppresses LH before the cycle begins, and then you need a long protocol where you use Lupron overlapping with the birth control pill. I'm going to show you later. Stop the birth control pill and continue the Lupron, and by the time the period starts, all the LH that's been expunged into the circulation by the woman's pituitary will have gone. Then you can start stimulation. And in poor responders or women with diminished ovarian reserve, when the period starts, switch from Lupron to a low-dose antagonist like ganirelix, cetrotide, or orgalutron. Avoid flare protocols, especially in women with diminished reserve and PCOS. And in my personal opinion, clomiphene and Femara all increase LH production, and I don't use those drugs in older women or women with diminished ovarian reserve. And frankly, I personally never use them at all in IVF. Okay, we're not going to go through all this. I'm going to quickly walk you through the protocol. This is the mainstay protocol that I use for my regular, normal responding patient who's young, who undergoes IVF. She goes on to a birth control pill, and then for a period of 10 days or so, she's on a birth control pill, and then it's overlapped with Lupron. I forgot to put in your birth control pill at this level, but she goes on a birth control pill for about 10 days. Then we overlap with Lupron, stop the pill, wait for a period. As soon as the period begins, we give the woman we start stimulating the woman with FSH, dominant products like Follistim or Gonalef or Puragon, which are recombinant DNA FSH. And we give it until there are at least 2 follicles between 18 and 22 millimeters. I rarely like to go beyond 22 millimeters because that over-ripens the follicle and the eggs become over-mature. So you want to use it until you get at least 2 follicles over 18 millimeters, but less than 22 millimeters, and at least half the follicles are over 15 millimeters. Then I trigger with HCG, or 500 micrograms of Ovidrol, which is 2 vials, and then I do an egg retrieval 36 hours later. Here is a variant. This is a better protocol to use in women with poor ovarian reserve or women who have diminished ovarian reserve and need higher protocols of stimulation. Here again, they start on a birth control pill. Again, we overlap the pill with the agonist. By the way, the birth control pill is given for 2 reasons. Because by shortening or lengthening it, you can predicate exactly when the woman is going to have a period. And also you can shorten or lengthen the time in the pill to manipulate it. And it lowers LH and FSH. And the lowering of the LH is beneficial because it gives the ovaries a breather from overproduction of testosterone and androstenedione. And then I overlap the birth control pill with Lupron, Buserelin or Superfact or Decapeptyl, all of which are agonists. I do that for 2 days while they're on the pill, then stop the pill and wait for a period. The moment the period begins, we start stimulating with Follistim or Gonalef, which is recombinant FSH, and then we add to that a small amount of Menopur. When I say small, I don't give more than 75 units, and usually half that dose, 37.5 units added to this. And I add an antagonist. From the day the period begins, I switch from Lupron to ganirelix, cetrotide, or orgalutron in half the regular dose. The normal regular vial contains 250 micrograms of those products. I cut it in half and use half of it. And give that all the way to the day of HCG, which is given as before when at least 2 follicles are 18 to 22 millimeters, and half of the remainder are over 15 millimeters. And then I trigger with 10,000 units of HCG, no less, and 500 micrograms of Ovidrol. But in my opinion, this is redundant. You don't need to use Ovidrol. It's much more expensive, and it has no other benefits over regular urinary HCG. This is the microflare protocol, which I don't think I never use it, but it's a protocol that many do use. The most important thing when you use this protocol is to use it on younger women that have normal ovarian reserve, not on older women and not on women with diminished ovarian reserve, in my opinion. And you always start it on a spontaneous period. never started coming off a birth control pill, because that will mess up the stimulation anyway. So then you start the Lupron, and at the same time, within a day or two, you start stimulating with Follistim Gonal-F, and again, when the follicles are adequately developed, you trigger with HCG or Ovidrel. This is a short antagonist protocol. Here, the woman is given ganirelix and cetrotide. This is the traditional way it's done. I never use this protocol. Many do. I'm not decrying it. It's an So where did you lose me?
Just like the beginning of the slide.
Beginning of the slide.
It was just,
Okay, we're talking here about the short antagonist protocol. Let me just repeat this in case I lost some of you. This protocol needs to be started off a spontaneous period. If you start using the short antagonist, the one that's traditionally given to most people, coming off a birth control pill, then the birth control pill will prevent proper antral follicle recruitment, and in my opinion will interfere with synchronicity of stimulation. So you don't want to use this protocol unless the woman's not been on a birth control pill. And when the period starts, you start stimulating with the FSH, and then 6 to 8 days into it, you start giving the antagonist, ganirelix, cetrotide, or orgalutron at a dosage of 250 micrograms daily, and when follicles are optimally developed, you stimulate. This protocol is fine, in my opinion, for younger women who have normal ovarian reserve. It is not optimal. It is, in my opinion, disadvantageous to use this in older women or women with diminished reserve, because during these 6 to 8 days here, before you start giving the ganirelix or the antagonist to block LH, you're doing nothing to suppress the effect of LH on the stroma theca of the ovary, and to block the increased testosterone production. That is fine again in a woman who doesn't have diminished ovarian reserve and in a younger woman, but it's not good in a woman with diminished reserve who's already got increased LH testosterone production. So if you're going to use this traditional protocol, in my opinion, it's ideally suited for women that are younger with normal ovarian reserve, not for older women with diminished reserve, and then always, in my opinion, start it off a spontaneous menstruation, not coming off a birth control pill. Mini IVF, as I said, I don't do mini IVF with clomiphene or Femara. In my opinion, the pregnancy rate is diminutive. It's under 10% per cycle. And clomiphene and Femara cause the ovaries to produce excessive LH. So I don't believe that this is the right way to go in exactly the people for whom it's often espoused to be ideal, namely older women with diminished reserve who are at risk of too much LH-induced testosterone. So I don't use clomiphene personally for Femara. There are people who have a difference of opinion, and that's their right. But in my opinion, it's not the ideal way to go. When I do mini IVF or even easy IVF, I usually stimulate the woman with very low dose gonadotropins, and I reserve mini IVF and easy IVF for young women who are with normal ovarian reserve, so they don't have the risk of increased amounts of testosterone. And I never use mini IVF in women who are older and have diminished ovarian reserve. Natural cycle IVF, to me, it has no place, because you're going to get 1 or 2 eggs and you've got to go through all but the drugs. You go through exactly the same that you would ordinarily go through in a regular IVF cycle. But you get fewer follicles, fewer eggs, and very poor results. So I don't use natural cycle IVF in my practice. The closest I'll get to that is mini IVF or micro IVF in a younger woman with normal reserve with low dosage stimulation with gonadotropins. So what are the other considerations? What do these other things work? We've spoken about DHEA, and I told you I advise strongly against it, especially for older women and women with diminished ovarian reserve. Human growth hormone, I do not believe it works. Brian Lieberman, who was one of the first people to describe the use of human growth hormone back in the early 90s and late 80s at Hammersmith Hospital in England, is a good friend, and I know that he would say today that the results of the work that he did with human growth hormone did not deliver what he'd hoped they would. In my own experience, we ran a trial with human growth hormone in women who have a poor response and have diminished ovarian reserve, and it was very disappointing. There are isolated cases where it may work, but as a general rule, it doesn't. And so I don't use it as a general rule. I use it in very isolated cases. Then there's the estrogen priming protocol. In this protocol, before you start the stimulation with the agonist-antagonist protocol, you first give about a week of estrogen to try to prime the follicles, the granulosa cells inside the follicles, to be more responsive to FSH. And this does work if it's done properly. This does work. You go on a birth control pill, you overlap with Lupron, as I described before. You have a period, and when the period starts, you switch from the Lupron to an antagonist such as ganirelix, and combine that with estradiol valerate injections or skin patches of estradiol, and that's continued for a period of 7 to 10 days. And at that point only you begin the stimulation with gonadotropins, and predominantly FSH, recombinant FSH, dominant gonadotropins, and many women who otherwise would be poor responders will respond much better. I'm not going to talk about the other things, I've mentioned them already. This here is again the estrogen priming protocol. Birth control pill, overlap with Lupron, wait for the period to come, then start the antagonist, ganirelix, cetrotide, or orgalutron, and add estradiol, valerate, or estrogen patches. I prefer the injectable estradiol valerate because you can control the dosage better, and you only have to give it twice a week in a little small subcutaneous injection. And then you start the stimulation about 7 to 10 days after starting this process with the antagonist and the estrogen. Give Follistim or Gonal-F, and then add a small amount of Menopur after the 5th day of stimulation, and continue to the point of the HCG trigger. Who benefits from this agonist-antagonist protocol, the estradiol valerate priming or estrogen patches priming? Older women and women who have diminished ovarian reserve. I don't want to talk about this. Thank you very much for your attention. I think that's enough to get a lively discussion going, and we'll go now to the discussion section. So those of you who have not posted your questions, please post them now at the appropriate place. I've just got to step out and find Tom to come and set me up for this. Here he is. Tom, can you set us up so I can see the questions that are being asked? Here we go. Just stay with me for a minute as he fixes us up here. Okay, so these are the questions, right? It started at where do I start? At the bottom here? Yeah. How do you improve egg quality for a woman age 40, PCOS patient? This is a very good question. First, in my opinion, You've got to down-regulate the woman's LH, which is always elevated or usually elevated in women with PCOS. So I put the woman on a birth control pill to bring her LH down. Then I overlap with Lupron, stimulate her, and allow her estradiol level to go and climb. And I see her 7 days later and do an ultrasound. If the estradiol level is climbing above 2,500 and she has more than 25 follicles, then I use a process called prolonged coasting. I gave a webinar. You can find it on this site by going into the archives and looking up on how we deal with ovarian hyperstimulation syndrome, because women with PCOS are very vulnerable to this. And if you don't stimulate them long enough and continue till the follicles are large enough, they will get very poor. They will overstimulate and put their lives at risk. And if you trigger them earlier, the eggs will be inadequately developed and they will be of poor quality. So it's very, very important that you use prolonged coasting when needed, and that you stimulate with low-dose stimulation of predominantly FSH products. If you want to discuss this in more detail with me, I urge you to call and set up a Skype consultation with me by calling Tina at 702-780-7437. Nushin writes, I've had first failed IVF and my FSH is 6 and my LH is 4. My doctor has asked me to start DHEA. I respectfully disagree with that approach. I've told you that I don't know that there's any benefit from taking it. It sounds like you could have normal ovarian reserve, so it may not do harm. But if you have a low AMH of under 2 or under 1 definitely, or if you're older, over the age of 40, I certainly would not myself recommend DHEA. But as I said, there are differences of opinion. And then heparin injections and endometrial biopsy, I don't think that that's got to do with egg quality. That's got more to do with implantation. And if you want to read about those approaches, then I suggest you go back in the archives and look for an article I wrote on implantation. And look for also the webinar I did on that topic, embryo implantation. Does over-medication ever cause poor egg quality? No, because unless you hyperstimulate, in which case you're at risk of having severe ovarian hyperstimulation syndrome. Most women, if you over-medicate them with fertility drugs, the excess you administer will simply pass through their system. But if you get too many follicles and it forces the doctor to try and trigger a little earlier to prevent hyperstimulation syndrome, yes, then indeed you can end up with poor egg quality. The next one is, what are your thoughts on testosterone priming in someone with diminished ovarian reserve and egg quality issues? Liz, I think everything that I said in this entire presentation expresses my personal opinion that that's exactly the wrong thing to do, in my opinion, because testosterone priming will only cause more testosterone to get into the follicle and compromise egg development and increase the risk of egg aneuploidy. So no, I would personally not agree with that. Yes, there are some that feel differently, but I respectfully would totally disagree with that approach. Does acupuncture help with egg quality? No, it does not, in my opinion. Anna Head writes, your suggestions on the best HCG medication for the diminished ovarian reserve patient, human growth hormone medication. I think any of the human growth hormone medications that are available can be used, but I don't believe it works, as I said to you. And I told you that I'd done a study early in the 80s, in the early 90s, trying it, and it didn't work then. We've tried it in some patients now. I've rarely seen an advantage. But if you want to use it, then any of the human growth hormone preparations available can be used. Crystal Grigsby, I'm 35 years old, 2 failed IVFs, have been told I have diminished reserve, but my AMH and FSH are normal levels. Antral follicles only 2 to 4 during ultrasounds. 5 mature eggs retrieved. Something's wrong here, Crystal. You can't have a normal AMH and FSH and have such a low antral follicle count? Something's wrong. Either they're not stimulating you correctly and you have a normal antral follicle count, or the AMH FSH are misguided here. So I'd ask you to repeat that, and maybe also repeat the antral follicle count. I think you, depending upon how poorly you respond, you may need an agonist-antagonist conversion protocol that is quite aggressive. And if you're very severely reduced in your reserve, then an agonist-antagonist conversion protocol with estrogen priming. My first IVF, 18 eggs, 41 years old, only 4 made it to blastocyst. Well, immediately that's telling you something immediately, because with 18 eggs, you should have had possibly a better response. It may be it's got to do with the protocol of stimulation, but it could also be that all of the eggs were of poor quality and only 4 of them had a chance of getting you to a good quality embryo. But remember, even those that made it to blastocyst, the likelihood is that only maybe 1 of those, if you're lucky, would be normal. And again, if you're lucky. They want you to do a long Lupron protocol again. Yes, I think it is a good idea, and even better if you use a long Lupron protocol and modify it slightly by going to the agonist-antagonist conversion protocol. Emily writes, what do you think of using estrace in the luteal part of my cycle instead of birth control pills? You can do that, but why? I mean, priming you before you get to the point of taking the Lupron doesn't make a lot of sense to me anyway. We just take a sip here. My personal preference would be to overlap you, to put you on Lupron, wait for the period, and then the moment your period comes, move on to an agonist-antagonist conversion protocol if you need estrogen priming. Sarah writes, I'm getting ready to start my first IVF and choosing to do genetic testing. I have 12 FSH, I have 12.2 FSH and a 4.2 AMH. I guess that is in picomoles per liter, because 4.2 in American units of nanograms per milliliter would be perfectly normal. Your AMH wouldn't be 4.2 nanograms per milliliter. I wonder whether you're not from Canada, where they measure the AMH in picomoles per liter, and anything under 15 picomoles per liter is equivalent to an AMH of less than 1.5 nanograms per milliliter. But you may be a candidate for doing embryo banking. This is an excellent way for women with diminished ovarian reserve to do IVF. You go through a cycle, the eggs are harvested, then on the 3rd day they're biopsied for CGH testing when the embryos are 5 to 9 cells, or they're taken to blastocyst and biopsied then, and in both cases CGH testing is done to see which of the embryos are normal. If you don't get enough, you bank them, vitrify them, which is ultra rapid freezing that doesn't harm the embryo, store them and stockpile them over time until you've got at least 6 blastocysts stored, and then send the DNA from all of the biopsies done in all the preceding cycles off for a single test for CGH. You know which embryos are normal, and then you come back in a hormone replacement cycle and put back 1 or 2 CGH normal embryos at a time. This is an ideal way for women with diminished ovarian reserve to do IVF unless they do egg donation. How does a man's age affect the embryo quality? Only if his sperm count's affected, and while men do go through menopause, it's at a much higher age, and much less severely than women, of course. So the man's age, unless it's affected his sperm, should not really play a role. Where was I here now? Must go higher. I've done that.
You're dead. You started at the bottom, so you got to move back down.
Where? Oh, yeah, it is. My medication was 150 follistim and 150 menopur for the first few days. I know. First few days, then I dropped the menopur to 75. 18 eggs retrieved, none very good quality, and only 4 blastocysts. look, that's not really that bad, but perhaps it could be improved with tweaking of the protocol. My personal opinion would be to cut down on the menopur from the very get-go and to use the agonist-antagonist conversion protocol, starting with a higher dose of follistim. Anahid writes again, would you suggest PGD for DOR patients? Absolutely, Anahid. Again, embryo banking is the way to go to make hay while the sun shines. You get stimulated, have your eggs harvested, biopsy the resulting embryos on day 3, let the embryos go to blastocyst, vitrify and freeze them, and if there's not enough, then rest a month and do it again and again. When you've got enough embryos biopsied, send away all the biopsied material, the DNA, for a single analysis, and then decide which ones are normal based upon CGH, and put back the embryo one or two at a time, and that works very, very well for women with diminished ovarian reserve. It isn't as good as doing egg donation, but it is good. All right. I had 22 eggs retrieved, writes Hope. 11 fertilized and 10 made it to blastocyst. That's very good. And on this cycle, I got pregnant on the fresh cycle, but miscarried. The next FET cycles didn't implant at all. Hope, go and see a webinar I gave before on implantation, and read up on immunologic factors that affect implantation and endometrial thickness, and you'll see that it may well be that something else is causing you to lose your pregnancies, and you may want to go, or fail to even attach, and you may want to go to dealing with that through the appropriate treatment if it's required. So where was I now? Okay. Linda writes, my RE will have me on Lupron from cycle day 21 to 28, and then change to Ganirelix from cycle day 1. This is the same as the agonist-antagonist conversion protocol, but he's not using a birth control pill, and it's an acceptable protocol. I commend your RE for using that protocol on you if you have some degree of diminished reserve. Next one is, with normal FSH, you have a normal FSH and good AMH, that's still a good protocol for you, Linda. What does it mean when your follicles are empty? I think I described that in detail. No follicles are empty. All follicles have eggs, but sometimes the eggs won't come loose because they're grossly abnormal due to the woman's age or other factors, or due to the protocol. And then that egg stays glued to the inside of the follicle. The doctor can't get it out. The egg's only as big as a grain of sand. He can't get it out, and he can't extract it. And as a consequence, he tells you, or she tells you, your follicles are empty. It doesn't mean they were empty. The eggs are still remained inside the follicles. Does the ferritin level affect implantation? Not to my knowledge, Nushin. Can too much androgen cause implantation failure? Excellent question, Hope. If you've got too much testosterone around and it gets into the uterine blood in too high a concentration, it will reduce the ability of the lining to thicken properly, and it needs to be at least 8 millimeters and preferably over 9 millimeters when you get the HCG trigger shot. Otherwise, there's not enough of a layer for the roots of the embryo to grow into and form a good placenta. So yes, too much androgens are bad, and that's one of the reasons why women with polycystic ovarian syndrome, who notoriously have high androgen levels, testosterone and androstenedione, have often got thin linings. Would you recommend a urinary trigger along with Lupron trigger? No. Age 27 of PCOS can produce 4 eggs with 5 days of Clomid. If you're doing intrauterine insemination for PCOS or regular stimulation, then 50 milligrams of clomiphene from cycle day 2 to cycle day 7 is probably the good way to go. Here's a long question. Do women with endometriosis and women who are estrogen dominant have problems with androgens and too much LH2. I am in the middle of an IVF with Dr. Saleh in Dallas with SRM and had to stop after retrieval because a huge fibroid inside the uterine cavity which had to be removed. I had a tubal ligation prior to the procedure and the doctor cleaned the uterine cavity the night before the procedure. I'm pretty sure it was the fertility meds that produced the fibroid because I'm estrogen dominant. I doubt it. Fibroids don't grow overnight. That must have been there for quite some time. And Dr. Saleh did the right thing to store your embryos while you deal with the fibroid before you do the transfer. You did CGH testing. I think obviously Dr. Saleh used the right protocol on you, a long pituitary down-regulation protocol. I'm pretty sure he used on you, be it regular Lupron or Lupron agonist-antagonist. I'm sure he would have used that protocol on you, and it sounds to me like it was the right protocol. All you've got to do is you've got to deal with the fibroid in the uterus before you transfer the embryo there. Courtney writes, 25, first IVF cycle, 36 eggs retrieved, 30 fertilized with ICSI, 23 at day 3, only 6 made it to blastocyst. Well, you know, Courtney, you sound, although you haven't said it here, as if you might have PCOS. I can't comment without much more detail. If you want to call anytime at 800-780-7437 and set up a Skype consultation with me, ask Tina to do that and we can discuss this in greater detail. Jenna Marinelli writes, to follow up with my previous question about empty follicles. 29, no family history of diminished ovarian reserve, 2 IVFs, no response, IVF with egg retrievals as empty. Again, Jenna, remember, you can have poor egg development because of a less than ideal protocol. But if you have an FSH level of 19, you certainly, in my book, would have diminished ovarian reserve, which would set you up even more for empty follicles. You will probably need another IVF, but embryo banking might be ideal for you sooner rather than later. So give me a call at 1-800-780-7437 and set up a Skype consultation so we can discuss it. Where now? I've got to go up. Hi, Dr. Sher. Is there any... so there's one below it. Man over 50 will result in abnormal embryos? No, much higher age than that. Think of Abraham. He was, what, 90 when he had Isaac, right? Anyhow, it's a joke, but clearly age in men has much less of an effect on sperm than age in women does have on eggs. Tara writes, Dr. Sher, is there any foods, vitamins proven to help egg quality? Listen carefully, everybody. There is nothing out there that improves egg quality. Don't let anybody tell you differently. There is nothing. There are certain things that may harm egg quality. In my opinion, DHEA in an older woman or a woman with diminished reserve can certainly harm the eggs. But I know of nothing that has been shown and proven to improve egg quality at all. If a woman's going to take supplements, and I've got an article on my blog entitled Nutritional Supplements in IVF, and I urge you to read it. I also have an article on my blog, Use of DHEA in IVF, and I urge you to read that too. But the ones that we know are probably not going to do any harm, at least, is folic acid. That's the most important one. Coenzyme Q, and possibly fish oil. But other than that, I'm not convinced that anything has any real merit to try and improve egg quality. Wow. Age 45, borderline AMH. I'm going to stop right there and tell you, Angie, at 45, don't even mess with IVF using your own eggs, because only 1 in 20 eggs are normal, and the likelihood that you're going to get a stimulation that gets you to even have 1 normal egg is very, very small. I would strongly recommend you think of egg donation and do not mess with your own eggs. If you insist, and if you are absolutely determined to use your own eggs, then embryo banking with CGH or PGD, CGH embryo selection, and staggered IVF is the only only alternative, but even that is ill-advised at your age. Here we have another question. I have an AMH of 2.3, TSH of 1.37, FSH, 2 failed IVFs. My doctor thinks I'm a poor responder to medication. I don't know what protocol you're on, Stree, so I can't comment. I also don't know whether you may or may not have an implantation problem. Call Tina at 1-800-780-7437. Set up a Skype consultation so I can go over your case with you in detail and review your records. The last question is, just had a failed cycle, Denise says, with estrogen priming. I'm 40 with PCOS. This is my 3rd IVF. Always seem to get 16 eggs, but only 5 are mature. My doctor wants to do a 3-month Depo-Lupron cycle. Denise, you know, I don't want to sound contrary, but maybe your doctor's got a reason for doing that, but in my opinion, that's not what I would do. I think putting you on Lupron for 3 months is, in my opinion, not ideal. I would want to modify the protocol. I may want to start thinking in terms of estrogen priming, not estrogen priming, embryo banking, but I certainly would not be moving in the direction that you're going. Call Tina and maybe she can set you up so we can discuss your case sometime. I have had 3 IVFs, says Katie, each time receiving 27 eggs. First 2 cycles we had 4 and 6 fertilized, with 4 blasts each time. The third we had 14 fertilized, 12 blasts. I have had 2 pregnancies. One had trisomy 16, the other ended up at 15 weeks from complications. We have done a short antagonist protocol each time, using only Gonalef for the first 2. We added menopause the 3rd cycle, have polycystic appearing ovaries, but an FSH of 1.1 at baseline. Anything else you can think of? I think you're on the right course, Kate. I think your stimulation certainly worked if you got 12 blastocysts that were expanded. That's a good result. But I think you need to look into the possibility that you might have an immunologic impairment, implantation problem, and if not immunologic, then an anatomical impairment of your uterine lining. Anahid, this is going to be the last question I answer. It says, after how many IVF cycles would you suggest a diminished ovarian reserve patient should give up on trying with their own eggs? It's not how many cycles. The time to stop is when there's no remediable explanation for why you're failing. You don't just stop because you've done a certain number of cycles. You stop because what you've got causing you to have to do several cycles that are failing is not remediable. And that's all I can say. And I urge you, Anahid, to call and speak to Tina and set up a Skype consultation with me. Call 1-800-780-7437. Thank you all so much for attending this webinar. And if you have any further questions, post them on my blog discussion section, on the comment section, and I will respond to them, or go to haveababy.com and the SRM Las Vegas discussion board and post any questions there. Ultimately, for those of you that would like to, please call Tina and feel free to set up a consultation with me via Skype. Thank you all very much for your kind comments also. I appreciate very much, and I enjoyed it. I enjoyed doing the seminar. Have a wonderful evening.